Audio recording for this meeting has begun.
Okay, I would like to introduce everybody to today's speaker, Eric Schell. Eric is a certified public accountant and a master of business education, or business administration, and he is a principal at Stroudwater Associates in Portland, Maine. He has over 23 years of experience in healthcare financial management and consulting. His areas of responsibility are assisting rural hospitals improve financial and operational performance by developing effective strategic, financial, and operational plans, and evaluating and designing affiliation strategies between rural hospitals and larger hospitals that optimize the combined relationship. Eric currently serves on the NRHA Governmental Affairs Committee as well. So Eric, are you on the line? Eric?
Yes, ma'am.
Hi.
Are we ready to go?
Yes, we are ready.
All right. Good afternoon, everyone in the East Coast time, and good morning, everyone else. What's for lunch? Well, thanks again for joining. I know this is a tough discussion for many of us because we're not these accountants that are sitting in my chair, and so I appreciate you guys kind of listening in. My computer just went black. Oh, there we go. So anyway, what I'd like to do, first of all, there's handouts today. I understood from a couple folks last time that they didn't have the cost report handout, which would have made last presentations pretty challenging. In this presentation, we're actually going to go through some handouts as well. There's a handout it's a balance sheet and income statement of a hospital. There's a handout of a budget of a hospital, and then there's another handout that is the departmental reporting, an example from a hospital I was at several years ago. And those are going to kind of be the focus. Let's just go back a little bit and rewind, and for those of you who may be new to this, just talk a little bit about what we covered in the past presentations. Let's see, I've got to figure out once again how to work this. Here we go. Again, and I think it makes a little bit of sense to pay some attention to this slide too, where these are how I think about rural hospitals. And again, for as Leslie introduced, I'm that accountant, the accountant that wanted to be an accountant in 10th grade. So all right, stop rolling your eyes at everybody else in the room because it's not that funny. But being an accounting in the 10th grade, it's a good way to come in and looking at rural hospitals. There's a couple things that I see often, and often I look at rural hospitals that have underperformed, and it's because, or for whatever reason, there's allowed or become a separation between financial responsibilities and clinical financial responsibilities. It may be the clinical people saying, oh, that's that business side, we take care of patients. Or the finance people may be saying, you know what, we're just going to handle the finance, just you guys go just take care of clinical. Usually in those settings is where rural hospitals tend to struggle. We're all in the business of providing health care services, and we have to come together in that. The second bullet, again, it's just absolutely critical. The hospitals that I have seen who have struggled and have turned around on the dime, the word you hear over and over again is accountable. I was held accountable. We were held accountable. She holds us accountable. He holds us accountable. But it's that accountability that it's both the financial, clinical, quality accountability that you hear. I believe that historically I'm going to put this little guy on. I believe historically our department managers haven't been given a lot of the basic skills. They've been, the best lab tech on the bench becomes the department manager through attrition, and without a lot of the skills that are required to be that department manager responsible for the business of the lab. This one around the Six Sigma principles of Six Sigma is one of the first paragraphs in the book Six Sigma is essentially what gets measured gets managed. I always like to turn it around and ask folks to close their eyes but don't close them too long, but close your eyes and think for a second. So does that mean that what doesn't get measured doesn't get managed? And think about it, and often you'll smile when you get the answer there. And then again, transformation starts when we change the questions being asked, and I believe very fundamentally in at the end of this presentation today, at the end of the presentation 2 weeks or 3 weeks ago, that I hope that folks that took this presentation seriously, that were on the edge of their chair sitting through that cost report presentation, that they went to their CFO or administration and said, boy, I want to understand that cost report, or I want to understand information in that a little differently. Transformation starts when we change when we start asking questions. So let me just, what we're going to focus on today, I'm on slide 4 of the presentation. The first presentation, the series 1, we looked at this whole idea of the economic framework of a rural hospital, and we want to walk just spend a couple minutes on that. Last time we got together, we talked about the Medicare cost report, and we'll just talk a little bit about that. Today we're really going to focus on better understanding financial statements and the budget process and why that budget process is so important. And you're going to hear a kind of a passion in me around the budget. No snickering. The reason why I think it's one of the most important processes and outcomes that we can accomplish in the course of a year. So these are the two that we're going to focus on: financial statements and budget process. At the last is ultimately pulling together everything that we learned, and we're going to be focusing on departmental performance and how to evaluate your departmental performance. How do you think about how you contribute to the overall organization? And then we'll talk briefly around payer reimbursement. So departmental performance, payer reimbursement, that's going to be part of the next week's presentation. The whole issue of the economics of a rural hospital, just this is a review. We reviewed on it briefly the last time we talked, and I want to touch on it again for anyone that either was saying, boy, I really didn't understand it, or what are these charts and graphs? But it really comes down to this question of rural hospitals are fundamentally fixed cost organizations. When we look at costs, and we look at the variable costs are costs that specifically change with one change in volume. So, for example, if we go from a acute census from 11 at 10 o'clock at night to 12 at 11 o'clock at night, what are those incremental costs? Those are the variable costs. Everything else is in a rural hospital somewhat of a fixed cost or a step fixed cost. And when we start looking at that, 80 to 90% of your costs truly are of fixed costs, not directly tied to volume. And it's really important. I mean, that if we understand that, it really drives some of this, drives some of how we think. Let me just, I want to jump to this one slide. Let me just stay here. What this was getting at is this slide right here was saying that if you look at your acute unit, and if we divide our total costs by census, when we have very low census, because our fixed costs are so high, we have very high unit costs. As volume increases, those fixed costs, administrator's salary, CFO's salary, all of these costs become diluted over greater and greater volumes, which brings down your costs on a per unit basis. And that's really important to understand. When we talked about profit strategies within rural hospitals, we talked about 3 for all rural hospitals and then a 4th for critical access hospitals specifically. And the first strategy was decrease expenses, and when we decrease our expenses, our profit or our profit goes up, or our break-even levels drop back to much lower levels. So cutting expenses is one possible strategy. The other strategy was increasing fees, and the effect that has, let me go back. This is your revenue line. Excuse me, where's this little? Hold on. This orange is your revenue line for what. So what it's saying is that when you have, for example, 10 units of service, revenue to the organization is this amount right here. Expenses are this amount. The difference between here and here are essentially losses. As we grow grow patient volume, as volume goes out to the right, farther and farther, our revenue line goes up more and more and more, to the point where we break even, to the point where our revenue is greater than our expenses. So the second strategy is obviously increasing fees. And you can see increasing fees is a function of a number of things. One, it's your charge master, it's your third-party contracts, it's better revenue cycle functions, it's the cost report improvements, it's improved service mix. A bunch of different things result in increased fees. And when we increase fees, essentially what happens is our revenue line goes up. When our revenue line goes up, our break-even levels drop back. So strategy number 2 is increase fees. Strategy number 3 is to grow patient volume. And when we grow patient volume, again, our revenue line is orange, our expenses are blue, our break-even point on volume is right here. As we grow patient volume, what happens is as we push out the patient volume, the point, here's our expenses, here's our revenue, the difference between the two becomes profit. And so growing growing volume is something that we saw. And the last for critical access hospitals was increasing the percentage of our business that was not cost-based. And it all had to do with the revenue line and the slope of the revenue line. So it was really important. And I think the important part of that whole message was how important volume is in driving your cost structure. As we increase volume, our unit costs come down as we dilute our overhead expenses. And when we dilute our overhead expenses, our cost structure comes down and our revenue goes up, increasing that profit opportunity, or at least the opportunity to get back to break even. Anyone want to throw out any comments, questions on that? Just in a review kind of fashion. Remember, I'd like to hear you all talk. Your lines are all open. So if anyone's got any thoughts or comments, anything that they thought of over Thanksgiving, over turkey and pecan pie on Thanksgiving that they just have to bring up and talk about?
And your lines are on self-muting mode, so you have to press *# to mute or unmute.
And don't everyone respond at once, or we're going to have this flood of calls and the phones blow up. Great. Okay. So the next thing we wanted to talk about was the cost report. And I just want to make sure that and again, in a review fashion, this was our conversation right before Thanksgiving, and no one fell off their chair and passed out from boredom. So obviously, many of you were very interested in this topic. I think the takeaway, we're not going to go through the whole entire cost report, but the takeaways that we really wanted to leave folks with was the fact that, no, we don't want anyone walking out of this room saying, gosh, I'm going to go prepare a cost report now. That was not the intention at all. The intention was to show how costs for your department are often developed. In other words, they start off with your direct costs, salaries and non-salaries, and then a whole bunch of overhead expenses get applied to them, which often almost doubles your total costs. And then when we tie it back to the conversation about your total costs, your costs that were directly allocated to you, and then the ones that were directly attributed to you, and then the overhead costs that were allocated to you, you start off with very small variable costs. They grow into higher levels of direct costs. Then you get all this overhead allocated that you have no function at all on you, and all of that lands up in your clinical department as a cost. And when we start getting into the section of next week, when we start looking at departmental performance, it's really important that you understand how those costs are determined, and make sure that when we're asking questions of our CFO or CEO around our performance, that we make sure that we're thinking about costs correctly. So again, we're not going to go through any of the pages, unless anyone wants me to start walking through the worksheet A, B, C, D of the cost report. We can do that again if anyone's interested. All right, no takers on that. So let's jump to the new part of the report. And again, I would say that this section right here around financial statements, if cost reports didn't do it for you, I mean, I'd be surprised if they didn't do it for you. But the financial statement section of this report is just fascinating, really interesting stuff. So I hope you share some of that enthusiasm. I think the first thing is we've got some basic principles around financial statements that really. It's funny when you start talking to department managers when you're out in the hospitals, and we start, as accountants, we start talk about things as accrual basis or cash basis. You start to have people looking at you kind of funny. Either that or their eyes just kind of flicker, and they're really not really paying any bit of attention to what you've got to say. So let's just try to get out on the table. What are these financial statements and some of these basic principles? The first basic principle, obviously, is understanding the difference between the way our financial statements are reported. And we hear people talk about accrual basis versus cash basis. A cash basis financial statement is a statement of, for example, let's just talk about a statement, an income statement. If you are recording an income statement on a cash basis, essentially, when you receive the money on any type of revenue-generating activity is when you would record the revenue on your statement. When you paid the check or when you cut the check, that is when you would actually reflect the expense. Has nothing to do with when the actual service was provided. For example, in your own checking account, you worked 2 weeks. You let's just say, but your direct deposit goes in at the end of that pay period. So in your own checking account, your bank statement, essentially, if you're looking at a cash basis, that, let's just say that $1,000 payroll goes in and on one date and time, but it was after the fact that you actually delivered the services. You pay your Visa bill. You incurred expenses all during the month, but you didn't pay that Visa bill until 6 weeks after. So if you're looking at your own check account, if you're looking on a cash basis, you would record the revenue when you actually when you actually received the cash, and you would record the expense when you actually paid the check, not when you actually incurred the expense. And that's different. Accrual basis statements are different than that. An accrual basis, and this is the way all of your hospital financial statements are generally recorded. Sometimes the physician practices aren't recorded this way, but most of your hospital financial statements are on something called an accrual basis. And an accrual basis says that when the activity that's going to generate the cash occurred, that's when we record the revenue, regardless of when we get the cash. So let's think about that in terms of clinical services. You have an inpatient that stays in your hospital today. We're going to get paid, hopefully, in less than 2 months for that service, although that's probably a stretch for some hospitals out there. But you hope to get paid 2 months from now for that one day that generally you're going to generate let's say $1,000. you incurred the service today, you're not going to get paid for 2 months. In accrual basis financial statements, you would record that revenue, that income for that stay today, in today's financial statement, not 2 months from now when the cash was received. Now, on the other side of the expenses is similar. We incur payroll. Let's say we have an employee working today that's not going to be paid for 2 weeks. We would ineffectively, if we were recording financial statements on an accrual basis, we would be recording that expense today. So you're actually reflecting the revenue and expense when the activity was done rather than when you expect to pay cash. Most of our hospital financial statements are on this accrual basis. Some of our, physician practices, when we receive the revenue, some of that is on a cash basis, but overall you generally see accrual basis financial statements. Any comments or questions on those two concepts? Because once you understand them, you'll understand then it's kind of one of these building blocks for understanding the statements, your monthly reports that you get out when you're kind of looking at your budget to actual. Any questions? Again, not everybody at once. Okay? Good. Everybody understands that then. Fantastic. The next is a basic principle, is the difference between critical access hospital financial statements and PPS hospital financial statements. And this is an interesting one because generally a prospective payment hospital, when they record revenue, they pretty much know what they're going to get paid. They get a fee schedule from many folks. They record that revenue when it was earned on an accrual basis. So when we send the bill out, or we record that revenue, and we pretty much know what we're going to get paid. Now, critical access hospitals, especially when it comes to cost-based reimbursement, we really don't know what we're going to get paid by Medicare at the end of the year for a service. And so what happens is we tend to book our revenue for Medicare services in critical access hospitals based on what we received in prior year's cost reports. And this example, I just wanted to show you this example. Where did my green little arrow go? There we go. My green little arrow here. If last year's costs were $1,700, total costs were $1.7 million, and we had Medicare acute days of 1,844, the average cost per day last year was $930. So what that means is that during this year, as we're generally booking revenue in critical access hospitals, we're recording $930 per day as revenue on an accrual basis. Now let's assume that during this year, for some reason, we had a 15% decline in volume. We lost one of our key medical staff members, or there wasn't a flu season this year. Well, when that happens, if our days actually decrease from 1844 to 1567, our costs per day actually go up quite a bit. And this gets back to the economics that we talked about in session 1 and that we just reviewed here. The reason being is because the costs that went away were only the variable costs, where our fixed costs stayed fixed. So our overall costs went up. So we're recording revenue at $930. Our real costs are almost $1,100. The difference by the end of the year is $257,000 that if we're just booking revenue based on last year's estimates, we've understated our financial statements at the end of the year by $260,000. I mean, that sounds like, oh, Eric, you're just a numbers guy. That's just numbers. We'll just fix them at the end of the year. No one worries about it. Well, the problem with this is that if I'm looking 3/4 of the way through the year and I'm losing $300,000, I'm going to make some different decisions from an operations perspective. I might be looking for some people to kind of, let's see, cut, let go. How else do we want to call it? Ultimately, we've got to right size the ship at some point, and so it's critical access hospital financial statements are a bit of a challenge here. The alternative scenario is if we have a 15% increase in volume, our costs go down relative to the prior year, and so we've been over-recording revenue. And in this case, we would have over-recorded revenue by $171,000. And so here here the concern is you're getting this money, you're getting this $930 a day in cash. We've got all this extra money in the bank, so guess what we start doing? Oh, we give out some bonuses here or there. We, at least to the CFO, because usually CFOs generally deserve lots of bonuses. We start building new facilities, we do all kinds of stuff, and then at the end of the year, Medicare says, hey, guess what? You guys owe us $175,000 back. Well, we spent it. No, that's too bad. You still owe it to them. So anyway, the reason, more and more critical access hospitals, what they're doing, though, is they're starting to run some models to estimate their costs during the year. So that's kind of the basic principle number one. PPS hospitals, very easily. You record your revenue. It's based on the fee schedules, your Medicare fee schedules, your private pay fee schedules, and you pretty much know what it is. Critical access hospitals, unless you're running some type of an interim financial model to estimate costs, you're either overstating or understating your total bottom line. And the question is, or the issue is that you don't know if you're higher or lower. So that's one of the big concerns. The next guiding principle here, there's only 3 of them, so hang with me here, is and this is one you hear frequently, and it's amazing because people like me that have been doing this for so long, you don't even think that people don't understand the difference between gross revenue and net revenue. And gross revenue is your charges. Your charges are not necessarily what's your net revenue. Net revenue is your expected cash from your patients. The difference between your gross revenue and net revenue is something called what? Yeah, I heard all of you say it. It's contractual allowances, or in this case we call them revenue deductions, but it's actually contractual allowances. So generally we have in our charge, we have charges set up, and let's say for a MRI our charge is $1,500 for an MRI. But with Blue Cross, we've negotiated a contract, and Blue Cross is going to pay us $750. The difference between the $1,500, our charge, that's set up in our charge master, and the net that we expect to get from Blue Cross, the $750, is a contractual allowance. We will never, essentially we won't ever get that. In our financial statements, in our audited financial statements, the auditors don't even recognize gross charges in the statements at all because they're essentially a phantom number. What is important, though, is the amount that the third-party payers and Blue Cross and Medicare and Medicaid and your private pays are ultimately going to pay us. So this third principle is making sure folks understand the difference between gross revenue, which is your charges, and expected revenue, your net revenue, which is what you expect to get in cash from your third-party payers. Everybody reasonably comfortable with that concept? Because once we get those basics, then we can move into start talking about something. Now, here's your first handout now. There's a handout that it's a 2-pager. Actually, it's not a 2-pager. It's a 3-pager. And it starts off, the first page it says balance sheet unaudited. There's a column that says December 2008 and another column that says December 2007. The next page it says operating statement on it. And the operating statement shows, this is actually for the month of November 2008, for the actual December 2008, and then prior year with variances. And the third page of this analysis, which is going to look like slide 48 of our presentation, it's the year-to-date operating statement. Okay, so what we've got here is the first statement we're going to look at is we've got here, we're going to go back to the presentation, is slide 48, is the income statement. And the income statement, there's a difference between an income statement. Okay, so let me just start. There's three basic financial statements that folks generally are required to prepare. The first is your balance sheet. The second is your income statement or statement of operations, or there's different names for it. And the third is your statement of cash flows. We're gonna not talk about the statement of cash flows because that we start getting into talking like real geeky accountants, and we really don't need to be going there with you all. So let's just pay attention to the operating statement or the income statement and the balance sheet. The first point we have to note is that on an income statement, it's a reflection of amounts either earned or expenses incurred over a period of time. So what does that mean? If we're looking at your handout on the second page, the period of time in the handout is 1 month. So it's all of the 30, let's see, what are we looking at? November. It's all of the 30 days of November and the 31 days of December. It's the summary of all of those days accumulated. All right, so that's what it's saying. It's amounts earned or incurred over a period of time. Now, to contrast that with your balance sheet, the balance sheet is a statement that reflects balances at a particular date and time. So at December 31st, my cash balance was $2 million. It's specifically at a point in time, whereas an operating statement or income statement is incurred over periods of time. So on this income statement, and we're going to have a quiz when we get done with this, so pay attention here and no dozing off. Billy, stop talking. So what we've got is we've got revenues and expenses. Revenues are amounts earned for providing services or selling assets, and expenses are amounts incurred for services or assets provided. In this case, what we've got, just like we just looked at, we have gross revenue, which is our charges. This is for 2008, 2007. We back off all of those contractual allowances. And all those contractual allowances, again, are the amounts that we were never going to collect anyway. It's the difference between our phantom charge, that $1,500 MRI charge, and the amount that Blue Cross is going to pay us, or $750. So the net revenue is essentially the cash that we generated on charges of $71 million. So in other words, we're selling services or assets. When we sell those services or assets, we end up in cash, essentially revenue. Revenue is essentially cash. The next thing we have our expenses. And our expenses, we've got salary and benefits, medical professional fees, supplies, purchase services, bad debt, other operating expenses, total expenses. Total operating expenses. This hospital chose to break out capital, which is depreciation and interest. Then you have your net earnings, any non-operating income, and then your net income. So the income statement, a couple points. Again, I just want to rehash. It's an accumulation of amounts over a period of time. If you think of your checkbook, it's the activity. It's all of the checks that you write over a period of time. When we go to talk about the balance sheet is your check balance at the end of that period of time. And let's just jump to the balance sheet so we can talk a little bit about that. Now, balance sheet, there's a couple different pieces of the balance sheet. This, again, it reflects assets, so things that you own, or liabilities, which are things that you owe at one point in time, at the end of the month, at the end of some period. And it's not an accumulation over time. Well, it's the result of, these are the result of the earnings and losses that are incurred on the income statement. But in this case, you've got assets, and these are resources available to an organization. And generally, a balance sheet is broken down into current, non-current, and then total assets. So this is kind of the left-hand side. And you've got things like cash, you got accounts receivable, we've got inventory, prepaid expenses. These are all things that we own. We've got Medicare, Medicaid settlements, ouch. We've got the land. We've got our total purchases, property, plant, and equipment. This is our land, our buildings, our equipment. accumulated depreciation. So this is all the accumulation of depreciation over time. We've got our net. So in this hospital, we've got total assets of $28 million. And this is a real live critical access hospital. The next side of the balance sheet is so you've got the left side of the balance sheet, which is the assets. Then on the other side, you've got your liabilities. These are amounts that the organization is owed to somebody else. In this case, you've got at the end of December 2008, so December 31st, 2008, we owned $3.1 million to accounts payable vendors. We owed $1.5 million to salaries and wages. We had a note payable, we had a bond payable, we had capital lease obligations, and we had total liabilities. So that if we add the current liabilities to the long-term liabilities, you come up with total liabilities. The next piece is called the fund balance. And the fund balance it's essentially an accumulation of all of your profits over the time that your organization was in existence. In this case, it was the $15 million right here. It's essentially, if you start with the $22 million here, you subtract from it, and this is in very general terms. I hope there's no accountants on this call. Chris, if you're listening to me, please, the Price Waterhouse background, you're going to shoot me for this. But essentially, a fund balance it starts with last year's ending balance, and then you add to or subtract this year's earnings to come up with the where you are today in your fund balance. But ultimately, your liabilities and net assets here, the right-hand side, is going to be equal to, I'm going to flip back a page now to slide 49, the $28 million, which is the total of your assets. So what we've got here is we've got this is a point in time, December 31st, 2008, our organization had assets, or things that we owned and available for sale or otherwise, or our resources available to us, of $28 million. We had liabilities, short-term liabilities in this case of $12 million, longer term of $642,000, and an accumulation of time of all of our earnings of $15 million. The total of which, the $28 million, equals exactly, I'm going to flip back to the $28 million of assets. Now what I want folks to do is I want you to take a look at the handout that you have, the 3-page handout. And I want you to look at the balance sheet, which it should be the first page on it. It starts off with it says current assets, cash, accounts receivable. And then you don't have to look at the monthly, but then jump to the third page, which is your year-to-date operating statement. And I want someone to tell me a story about this hospital from looking at these financial statements. And I want you to unmute your line, and I want you to share with me some observations about this hospital and what may be going on with this hospital. And there's going to be a very uncomfortable silence if somebody doesn't jump in.
Hey, Eric.
Sure.
It's Chris.
Hey, Chris.
I noticed on the balance sheet that this hospital had a long-term debt that now looks like it's due in the next year from 2008 of about $6-7 million.
Okay. Great point, Chris. Chris is from Price Waterhouse, one of the premier accounting firms in the country, so we would expect him to nail this one. Absolutely right. Something happened to this hospital where they had a long-term bond payable. You can see it right here on slide 50, or on your handout, the balance sheet, down about almost 3/4 of the way. You see $6.9 million bond payable. That was at December 2007, and in December 2008, that whole bond payable became current. Now, when you've got debt outstanding of $7 million and it all becomes current in 1 year, that's not a good thing, because somebody's going to have to pay that off in a hurry. What else is going on with this hospital? Tell me why that might have happened. Somebody other than Chris. He could have written the book on this thing. Billy, you're out there. Billy, you're CFO. What happened to this hospital where that bond went current? Calling Billy out and he's not responding. Let's take a look at the income statement. Is there what's going on here with the income statement? I'm on slide 48 now, for those of you who don't actually have the handout. What's going on here? This is a critical access hospital in the Midwest. What's going on here, folks? I mean, somebody's got to chime up. There's some pretty obvious stuff going on on the income statement, the revenues and expenses related to this hospital.
Yeah, they violated their bond covenants. They're in default on bonds.
That's exact. And how did they go on? How'd that happen?
They didn't make enough money.
How much money did they make?
They
Negative
lost.
$4.5 million.
This hospital lost $4.5 million in 1 year. Generally, that's not such a good thing either. So you can see that, and tell me where some of those losses were. Think back to our economics discussion. Think back. So think back to our economics discussion about the importance of volume.
Well, yeah, the revenue's off over $2 million, and their expenses are actually up.
Right. So you can see that our net revenue is down. So volume and charges are down, right? So just charge. Well, these guys had a 5% charge master increase. I didn't tell you that. I'm leaving out certain details here. So, but these guys had a 5% charge master increase, and even so, their charges year to year were down $1.3 million. Their overall net revenue was down almost $2 million. Their expenses. Look what happened to their bad debt expense. Their bad debt expense went up $1.2 million in a time in which their revenue went down, their gross charges went down $1.3 million. So clearly they've got issues with bad debt. Their staffing remained constant. Their volume went down. These guys got themselves into a world of hurt. And you know, you think back to our discussion around how important volume is to your overall cost structure. These guys' cost structure, again, if we put most of our costs are fixed, that would explain essentially a decline in volume, but our staffing, a decline in volume, but overall our expenses remain relatively constant, resulting in a huge decline in profitability. The result of that decline in profitability was that there was two results. One is that as Chris pointed out, that we took a bond payable that was a long-term debt that we were paying over long-term, probably 30 years, and because we broke our bond covenants. Well, often when we have debt, we have covenants associated with them that say that you have to maintain certain ratios, you got to be profitable, you got to do all of these things. And if you don't, essentially what we're going to do is we're going to make that thing current. And when you make that current, essentially we could call that bond at any one point. Now what happened to this hospital is exactly that. Hey, Chris, you can even pipe in on this one. What's happened here on slide 49 now that you know a little bit more about this hospital, what happened on slide 49 here, which is your assets?
But it looks like they got a negative settlement where they're going to have to pay some money back to Medicare.
Yeah, they absolutely. Medicare came in, found prior year cost reports. They had some busts in there and assessed them a pretty huge fine. So that's one thing. What else do you see jumping right out?
Well, it looks like whatever that asset is, it appeared as a limited use. I don't know.
Absolutely. You see this $3.7 million? What happened was because they defaulted, these guys had essentially a bond-designated fund set aside for the bondholders. When they defaulted on their covenants, the bondholder took this money, $3.7 million, put it into a restricted account, so pulled it out of their cash, pulled it into a restricted account, and then 2 months after the end of the year, they actually pulled that $3.7 million right out of the hospital altogether. So now here's a hospital that struggling, lost $4.5 million. Bonds went current because of default. The bondholders took $3.7 million out of their operating cash, put it into a restricted fund at the end of the year, and then 2 months later yanked that cash completely out of the organization and put it in their own pockets to partially pay off some of the bonds. This hospital's in a world of hurt. So I think the point here is an interesting story about a hospital here, but I want you to see that when you start looking at these financial statements, you can almost see stories developing, kind of just from looking around at the numbers. And frankly, when I'm looking at a financial statement of a hospital, I'm always looking to see what the numbers are telling me from a story perspective. Any thoughts from clinical managers on this? I mean, do you kind of see this at all? Are there any clinical managers out there today? We'll assume no. Hey, Chris, this is your and my call.
Okay, Eric.
Clinical managers are getting it.
They are?
Yeah,
Okay.
they are. They're seeing it.
Well, who wants to hear the rest of the story?
All of us.
Anybody want to hear the rest of the story? That was a hospital. That was interesting because they had this hospital that was a critical access hospital. They actually had their own cath lab. So it wasn't like most of the one that I've seen in the Delta. Actually, I don't think I've ever seen a cath. Yes, I have. I've seen one cath lab in the Delta. But this was a critical access hospital, pretty size. You saw $70 million in charges, so they were definitely of size. In order to be a critical access hospital, they were used to run an average daily census of somewhere between 27, 28 in that range. But they thought that by becoming a critical access hospital, they could pick up an additional $2 or $3 million. So what they did is they shrunk their average daily census from about 25 to 18, and assumed that cost-based reimbursement would just save them. But we all know from looking at the earlier stuff and the earlier presentations that you can't just drop your census by a third without cutting any staff and expect to be successful. And that's what they did. They at the time we were there, they had 401 FTEs, and just they literally were the same staffing size as they were when they were running an average acute census of between 25 and 27. And now they were a third less size, but they kept all their staff. So essentially what happened is a new department manager, or a new CEO came in the end of November. They brought us in just to help her think through some different ways to look at things. And by the end of that next year, she had turned, and she was one that when you talk to the department managers, they would say, she held us accountable. She held us accountable. By the end of the year, that hospital turned it around so much that it made $1 million profit. Now they had to right-size their staff. They had to cut about, I believe it was, they were down to about 340 FTEs, so they had to lay off about 60 people. Which is sad, obviously, but a critical access hospital of this size, running a census of 17, really can't support 400 FTEs. And they all thought of it as that we have to lay off 60 FTEs to keep the 340 that are going to be stay. So anyway, that hospital right now is it's a great little place. The CEO is a wonderful CEO, and they've really turned around on the dime. So great story. They refinanced their debt. They got that one bondholder off, and it's a happy story after those shady times back in early 2009. Anyway, good story. All right, let's move on now. Let's talk a little bit about the departmental financial statement, because I think there's some interesting observations here we want to make. First of all, there's a second handout. The second handout is, it says at the top, RBH, Departmental Financial and Statistical Information, year-to-date period ending 4/30/08. The first page, in the top left-hand corner of the actual inside the statement, it says administration. The next, there's food services. The next is radiology, and the next is laboratory. And what I wanted to do was give you a mix of support function, budget, departmental statements, and then revenue-generating departmental statements. And if you just take a flip through here, I really like, and I like to share this as an example, and if you look at the handout, you can see that this hospital has essentially developed interesting statistics for each of the departments. For example, administration is looking at salaries and wages per EPD, the supplies per EPD, equivalent paid day. I guess that's what they're looking at, salaries and wages per equivalent paid day. And so each department, and you look at radiology, they're looking at inpatient revenue per procedure. If you flip the page, a couple pages in, you'll see inpatient revenue per procedure, outpatient revenue per procedure. So they track a lot of very interesting statistics as part of these reports. So anyway, let's just take a look. This is, when we look at these reports, and I hope all of you or most of you are getting some type of a report that looks like this. And we'll talk a little bit about why that I feel is super important in a minute. But when we're looking at this, first of all, this is a radiology department. And in the radiology department, we've got patient revenues. You've got year-to-date. So this is the year-to-date column. And in this case, our total patient revenues were $1.7 million. We had a budgeted amount of $1.9 million. And the prior year to date was $1.78 million. We have expenses, and there's no overhead expenses associated with these, so these are our direct expenses. We got salaries and wages, supplies, physician fees, purchase services, other total operating expenses, and then we have a gross margin for radiology. Now, first question I have for you, and accountants are not allowed to answer, how much money did radiology make for the hospital? Any idea? For all of these that you were looking and saying, boy, I'm the radiology department manager and we made $1.5 million for the hospital, we are superstars because the overall hospital only made $30,000 this year. They are absolutely wrong. Sorry. The difference, when we talk about here, the difference between a hospital P&L, so what we just looked at, the income statement, and a departmental, are most departmental reports don't have this piece right in here, which is the contractual allowances. Most of our financial reporting packages are not able to track that. So what we've got is, these are our charges, okay? These are our charges, and these are our expenses. Now, these are generally our direct expenses. What you don't see in here is employee benefits. What you don't see in here is administrative. You don't see a portion of the CEO's salary allocated to radiology. I frankly don't think you should. I think what you've got here is, these are the expenses that the department manager has very direct control over. I don't think she has or he has any control over what the CEO makes. If they did, that would be very ugly for the CEO. But anyway, so what we've got here is we've got charges, we've got expenses, we've got gross margin. Now, I have a number of hospitals that have told me we don't send reports out to department managers because essentially they're useless. The reason why they're useless is because then everybody goes around, all the managers going around saying how profitable they are and why isn't the hospital making money if all of our departments add up make $30 million. Tell me, how are these statements useful? if you're a department manager, tell me why, as a department manager, you want to have access to these statements. Why are they important to you? Another awkward silence if nobody jumps on.
You can check your expenses and your revenues with the budget in the prior year to see any changes that you need to make or where you are in relation to those two.
Absolutely right. Absolutely right. So, for example, expenses. Okay, we're over expenses from budget, but we're lower than we were from prior years. We start asking questions here. We at least we've got a number here. I mean, if I'm the department manager, I'm going to go to them and say, okay, how did you come up with this number right here, the 99,000? We were 107 last year. We're 99. What happened here? I would want to understand how we came up with some of these budget numbers from the expenses. The second thing I want to know is how am I doing? This right here is a reflection of volume, because of volume or mix. Either one, remember, based on the economics discussion that we had, volume is important and mix of services is important. So the charges here are a very important reflection of volume and service mix. Really important for department managers to be accountable for that. So ultimately, to me, this departmental statement, even though the gross margin number is woefully incorrect, what this does around holding department folks accountable for the business of their entity or their department is critical information. So the question down here is, how are they different from the hospital P&L? Well, it's different from the hospital P&L from two perspectives. One, it doesn't have the contractual allowances. So again, this gross margin is significantly overstated. And two, there aren't any overhead expenses. These are just the direct expenses attributable to this department, which, as we know from looking at the cost report, this woefully understates the true costs of the organization. So, department manager, radiology, you didn't make $1.5 million, but good on you for thinking you could do that. If you could sell that you made $1.5 million to anybody, good on you.
Hey, Eric.
Sir.
Based on that discussion, would it make sense not even to show that gross margin on that report if you could avoid it, because it is somewhat meaningless?
Chris, that's Chris, right?
Yes.
Chris, I got to tell you, thanks for joining the call. I know you weren't on the last two because nobody else talks, so it's nice having you join us. Absolutely, I don't think that this gross margin is relevant at all. And so I would, if your system would allow you to take it off, you could. Or if the extent that you can't take it off, you just let people have to understand what it is and how it does not reflect true margin from the overall hospital's perspective.
Okay.
Any other thoughts or comments on that? Okay, the second is similar. I mean, if you flip through this handout, this is looking at administration, and so what we've got here is that we've got our operating expenses, wages and salaries, supplies, physician fees, purchase services. Clearly, these salaries and wages here, this does not include the CFO, because the CFO would be 4 times higher than this in salaries and wages. Significantly too low. Anyway, so what we've got here is well, first of all, here my questions is how is this document, how is this report different from the ancillary department P&L? It's pretty straightforward.
Yeah, no revenue.
No revenue at all.
Yeah, no revenue. And guess what? That's because administration does not generate any revenue. They are, for the most part, well, I'm not going to say fat, but they're just overhead, let's just call them. But still, from administrator's perspective, or for anybody that wants to be held accountable, there is this opportunity to drive improved performance around managing the expenses. These are generally some pretty big expenses that we ought to be managing. In this case, we're pretty tight to the budget, so we're a little bit higher in purchase services, but other than that, we're pretty tight. So again, the difference here, there's no revenue at all, so we don't have to worry about gross charges, contractual allowances, net revenue. Really, this is just about accountability around expense structure. Let me just ask a quick question here going back to this. Do department managers, and I want to hear from a department manager on here, do department managers feel responsible for this section that I'm circling right here, which is the revenue?
Dara Jung chatted in, and she believes so.
Yeah.
Somewhat.
Somewhat. Others? Anybody? Anybody's got a voice? I won't pick on you, I promise.
Well, to some extent, they don't have any control over the patients that are in care, but on the other hand, they can promote their services when they are applicable.
I so agree. I so agree with the second half of your statement. I look at, gosh, usually you think about your hospital. You think about the entrepreneurs in your hospital. A hospital that we were just at this week, lab manager, super entrepreneurial. She had gone out, met with her physicians, went out and recruited the lab. She was, what else, Troy? Where? Other new opportunities in the community. She was out recruiting them, and guess what? Her volume in lab were one of the few ancillary departments that were showing a growth. I always look at the physical therapists. My gosh, these people just come from entrepreneurial school or something. You know, 3/4 of the physical therapists you run into are just energetic. They got that go. They go out. They work to develop swing bed programs. They really get involved, and they have this control or the feeling of control over my volume. And so I like it. And we're going to talk about this next week when we start looking at departmental performance. I've got some case studies of department managers that have really kind of taken the charge and kind of developed their own revenue. For me, the frustration is the department managers that sit back and say, we don't have the doctor's pencil or pen, we don't affect our volumes at all. Those are the ones that I'm generally am somewhat disappointed with. So thanks for sharing that comment.
And Dara Jung also said that they don't have control over what the physicians admit, but they can promote outpatient services.
Absolutely right. And outpatient services, it's funny, but especially for the critical access hospitals, remember when we talked about the whole payer mix issue within critical access hospitals, the generally cost-based reimbursement, the cost-based payer mix on outpatient services is usually, if you're just Medicare, it's usually around 30%. If you're Medicare, Medicaid, it might be 40-45%. But a majority of it is fee schedule. It has that real steep sloped revenue line. Every additional unit of service that we generate in outpatient, it's $200 or $300 or $400 or $500, where the costs are $20, $30, $40. So there's that opportunity to generate revenue on that. So outpatient services are just really important for an organization. And as Dara just noted, a lot of that is under the influence of department managers, the entrepreneurial department managers. So good stuff. So here's some things I like to see when department managers get their departmental budgets, and I encourage all of you that are sitting around the room that don't get them now to go sit down with your CEOs, CFOs, and really encourage that you want to understand where you stand. You want to have this information. There are some antiquated systems in rural hospitals in Mississippi that I've visited, even some recently, that can't provide this information. And what I would hope that as we move towards EHR and investments in IT, we will bring in systems that will allow us this level of review of financial performance. So here are the questions I'd like to see you all ask as department managers. First, that we review the actual numbers. We look at, ask the following questions. Are they reasonable? Do you see any unusual amounts of categories? If so, ask questions. Transformation starts when we change the questions being asked. Ask new questions here. Make sure there wasn't a posting error. I don't think, I don't know if, let's see. I think 6 years ago there might have been one accountant that's made a mistake, but this might be that new year, that the 7th year, and we might have an accountant make one mistake this year. So you want to check and make sure that there wasn't an error there. We want to review the budget numbers. Do they seem reasonable? Are they what we agreed to during the original budget process? Let's ask these questions. And then review the variance column. I like to have hospitals establish a variance threshold, and I know this is more for department managers, but ultimately establish a threshold, and anything above either a percentage or dollar amount threshold, that we require some type of variance analysis or some investigation into why we varied as much as we did. And then the question is, what threshold would you set? And I would sit down with your management team and develop that threshold around what is a dollar or percentage amount that we are going to seek out variation analysis from. So these are some of the questions that I would ask, or I would look to you to look into and ask as you look at these departmental reports. Some of the common pitfalls I see with departmental financial statements, and again, these are this handout that I shared with you. One, they're not sent out on a regular basis. One hospital is visiting, I sent them out, we got them out in January, but February we got busy, and we're going to get them out, our February statements, we're going to get those out maybe, early April. Ultimately what happens there, if they're not consistently out by the 10th business day or 14th business day of the month, or whatever the date is, it sends a message that it's just not that important. I believe these documents are absolutely critical to that accountability that we talked about on page 2 of this presentation. Common pitfalls, they often do not include contractual allowances. But I don't think, as we just talked about, that should be a reason why we just stop sending them out. I think the revenue, we look at revenue in isolation. We can focus on that as a measure of frequency and intensity of services, and I think that's important. The expenses, we can look at them as we just talked about. Often, if the statements do include a contractual allowance, especially for critical access hospitals, that the statement reflects not an accurate interim payment rate. I'd spend more time talking about this, but it'd be more specific to critical access hospitals. And I think David Letterman's #1 pitfall associated with the departmental action report is department managers file them circularly. Unless you're, anyway, and this is the big one. And it's funny, I'll sit down and talk to a CFO of a rural hospital, and they'll say, well, look, we email them out every month. And ultimately, so the question becomes, well, did you hear back from your department managers? Well, no, we just email. They all get them. They get them every month, and we send them out. The issue here is that if there's not some type of a feedback loop, often these things they're just not important to many. Some department managers, those entrepreneurs, are looking at them every month. They want to know. They can't wait till this thing comes out on the 10th day of the month so they can look and see how they did. Others who are less entrepreneurial, ultimately say, you know what, that's business stuff. I want to focus on taking care of my patients. Really aren't paying too much attention to them. So there we have it. David Letterman, #1, department managers file them circularly. So let's just talk about the budget process here in the next probably 10 or 15 minutes, and just get this up. I want to introduce the budget by saying, to me, the outcome of the budget process is probably, how do I want to say this? Let's just say it this way, that the budget process itself is as important as the outcome it creates. And I think, and what I mean here is that the process of engaging department managers in a process that overall assigns accountability throughout the organization up front, gets people bought in, shares responsibility among departments when we all kind of know each other's budgets and things, is absolutely that process of creating that document is such an important process that I think that process is as important as the outcome itself. And let's talk a little bit about that. So what's the budget? It's anticipated revenue and expenditures for the next year. It's a plan. It's used to plan, monitor, and motivate future performance. And I think the planning and the monitoring leads to the motivation. And what I mean by that is that, boy, if I'm involved in the planning of my own departmental budget, I can monitor and see where I am. If I get off track, I seek to get back on track. I motivate myself to get on back track. If I'm ahead of budget, often I want to beat the heck out of my budget at that point, so I'm motivated, but I actually get to see what I'm doing. So I think that the budget process and then the effect that has going forward is going to be really important. Used to allocate funds, their communication vehicles across departments, and then budget can be crucial in helping to balance cash flows and outflows. I always like to see a budget process, frankly, end with a meeting of all department managers. So here's a typical budget process. CFO sends out revenues, expenses, over 8 months, and then estimated year to date. You're asked to fill in your budgets for the next year. And you're given 2 weeks to pull in all this information. You meet with the CFO. You get all the information in. The CFO accumulates it. And then guess what happens? When he or she accumulates this information, all of a sudden the hospital's got a $4.5 million loss. Because generally what happens is we undershoot revenue and we overstate expenses. And everybody does it. What I like to see is everybody come together in a meeting, order a piece of a pizza, a couple pizzas, and we don't walk out of that room until that budget is a 2% operating margin or whatever the board mandates us to generate for the next year. And that to me is a process in which engages everybody. It shares information across departments. It creates this communication vehicle, and it's to me it's one of these best practices that I've seen out there in rural hospitals. I've got another handout here, although this one's not really that interesting, so we're not going to spend a lot of time on this one. It just shows a hospital that accumulated. This is the summary itself, and it's the handout is called Proposed Operating Budget, and the first page of that is just a summary page. The second page of that is what I've done just to get it on one piece of paper. This is actually about 30 different columns. I cut off 25 of those columns, and you can see that it starts at anticipated revenues, anticipated expenses, all agreed to by department managers, coming up with the year-to-date net income. In this hospital's case, the target is around an income of $1.1 million. So handout, not really interesting, but I just wanted to get you something out there that you could look at. This slide 58 is really just looking at going across, so going across the different departments. Here's Med Surg, OR, Lab, Imaging, ER, Admin, Business Office, and then guess what? There's 25 more of them that go all the way out that total up to the numbers that we see right here. In this case, we've got total revenue of gross patient revenue of $40 million, total operating revenue of $41 million. We have contractual allowances. Remember, we talked about those. We've got bad debt. We got charity care. So net patient revenue of about $26 million. When you, so what would happen is this document would get loaded into your hospital financial package, and then broken out on a monthly basis, and then you all would be responsible for, on a departmental basis, all of these numbers right here. This is pretty small, but ultimately what this is the same kind of departments: Med Surg, OR, Lab, Imaging, ER, and then 25 other departments that total up to the numbers you'll see here in the far right-hand column. And these are the expenses that you worked with your CFO, with your department on establishing your salaries and benefits and all other types of expenses. This is all loaded into a spreadsheet, comes up with a total. and that total is loaded into the overall budget, which then is loaded into the monthly financials, monthly financial statements. So there's a lot of stuff here in terms of budget uses, planning, it's a plan. The two that I see are the most important uses are the monitoring and the motivating. I'm sure if Chris, Billy, other CFOs out there on the call, they would challenge me. They're probably looking at other things. Learning, I think, is important. But to me, it's this monitoring and motivating, which I believe both the process and the outcome of the process over the course of the year built into your monthly financial statements are the critical pieces of the budget. So again, throughout the fiscal year, the budget serves as a control document to keep the organization on track. When we see our radiology volume in say April falling off 6 or 7%, boy, we got to sound the alarms. What is going on here? What do we got to do to get this back on track? What questions, when we know that that's going on, what questions are we going to ask about our performance there that's going to drive some performance? And ultimately, those from that monitoring and the observations that we note, that's going to motivate a very different performance. If the performance isn't very different, by the end of the year comes along, we're going to be in a heap of trouble. So I think that these two are some of the most important. And you got some others here. Here's kind of a schematic of a budget, a reasonable budget process where we establish our volumes first. That establishes the revenue. Out of the revenue, we have a demand for expenses, the direct, labor, expenses, labor, super overhead, and that's cost, and that develops the administrative. We got an income statement and balance sheet. So this is just a picture of a kind of a textbook picture of what a budget process looks like. What are the characteristics of good budgets? Obviously, they communicate what is expected. At the end of the day, especially if we go through the process of sitting down with all our managers and reconciling this department, we've communicated to everybody on our management team, both senior management team and the next level down, department managers, what is to be expected. It's guidelines and directions. Improves day-to-day decision-making. Again, if we start to fall off of our budget, we've got to ask very different questions, and on a day-to-day basis, we want to be tied into making sure that we're accountable to that budget. Provide this early warning system. Again, if in April our radiology volumes are off 7 or 8%, boy, that's early warning. We got to jump on that, because if we let that continue without asking different questions in April, by the time that manifests itself through the end of December, we could be a significant loss just from loss in volume in 1 or 2 key departments. Interdepartmental coordination, again, especially when we sit down and the budget's shared among all of our managers. So some signs of weak budgeting process. Gosh, just seeing what being out there on the road. I think some of the key signs of a weak budget. One is that department managers get their information together. The CFO accumulates the data. It shows a $4.5 million loss because, again, everyone's low-balled their volume, high-balled their expenses. And guess what? The CFO and the CEO sit down and they fix the budget so that it results in $1 million profit. And essentially what had just happened there is we took accountability away from the department managers. The budget is no longer ours, it's theirs. We lost our first and probably most important tie-in to performance. So I think, I'm not even sure where that one is, but I'm just, I guess I got to look through the bullets here to find out where that one is. But that's one of the weak budgeting process things I see out there. Goals are often off target, unrealistic. Here's one: the hospital lost $1 million last year, so let's just increase our charges and net revenue by 10% and we break even. Well, how are we going to do that? Well, I don't know, but we'll just increase it by 10% and we're going to break even. Process takes too long. Now, come on now, somebody's chuckling out there. They've never done that before now, have they? I think we can look. Let me just see which ones. This no communication between budgeting staff and operating staff. I think more appropriately, this is one that, boy, I was at a hospital several years ago in the Midwest obvious outside of the Delta because you guys don't do stuff like this, where essentially the budget process was the CFO locks himself in a room for 2 days, comes out with a budget and hands it to the board, and that's the budget. This was the same hospital that they had started off with about 70 days cash on hand 2 years before we got there. By the time we got there, they were down to about 8 days cash on hand, but the CFO had everything under control. He resigned the day before we got there to visit him. So you know, the budget process has to be a process that is interactive between the operating staff, the people that are out there in the field making the decisions that are going to have the biggest effect on the budget, and the darn CFO who's sitting there accumulating it. So I mean that's you know, really important. Managers, and I think that ties into this next bullet, managers have little or no knowledge of the budget. That's the CFO that locks himself in the office, comes out 2 days later, hands it to the board and says, here's our budget, folks. Budget is ignored. Variants are investigated. Again, I think the whole budget during the year, once we establish the budget, if we don't investigate and then, oh, by the way, create plans to correct the budget, we can get off track really quickly. So successful, I have critical access hospitals here, but ignore that. Just successful rural hospitals, department managers are involved in developing the annual budgets. And oh, by the way, not just the expenses. For the ancillary departments, it's as important to you to be involved in the volumes and being accountable for the volumes as it is the expenses. And matter of fact, based on the fact that, remember the revenue lines of expenses relatively flat, not a lot of room there, mostly fixed expenses, where the revenue line, the slope of the revenue line is very steep. I frankly want department managers more accountable for revenue than they do expenses, because revenue is harder to manage. And that's where I want my great entrepreneur managers focusing. The budget to actual reports we sent, they're sent monthly. We don't have any more of these folks that say, well, they show this gross profit, that's not accurate. And because they're not accurate, we're not going to send the statements to you. I like to put the analogy that it's kind of like if we send all our people into a grocery store and there's no prices on anything in the grocery store, generally we tend to head in the direction of the steak and expensive wine department if they sell wine in your grocery store. They do here in Maine, so that's where I tend to go when there's no prices on anything in the grocery store. The second piece of this is the variance analysis. The important critical access or rural hospitals have this required variance analysis so that there is ongoing discussion, dialogue, feedback. I like to see quarterly operating meetings, or if not, I had a hospital in Michigan, CEO once a month sat down with every single, she called them the monthly ops reports or something, or meetings. Every month for an hour, she sat down with all of her department managers and reviewed the budget to actual report. I think that might be too much, but at least a minimum on a quarterly basis, we ought to have some regular communication between department managers and CFO. And again, I want to say this is all in the realm of linking back up clinical and financial. Create charts of key departmental performance indicators. I had a CFO in a hospital in Nebraska. For every department, she created 4 performance measures for each department that they looked at every month. And at the end of the month, if we score on these 4 performance measures, we've had a successful month. And that was a great thing. It engaged people, all kinds of stuff. So I really like that. Frankly, this is what I really wanted to talk about today, was the financial statements and budget process. The next two, the departmental performance and payer reimbursement, is going to be, we're going to hold those till next week. So, you know, I guess my concluding comments related to this is if we understand the foundation of how financial statements are accumulated, the accrual basis nature of them, how we look at gross charges, how gross charges are different than net revenue, how our department, and then when we carry that over to the budget process, and then the budget process being a really important piece to the monthly financial reports that you get, the budget to actuals, I think you can see why I see this as such an important part of linking rural hospital finance and operations and clinical all together in the business of providing healthcare services to our rural communities. So let me leave, I'm going to leave the next 5 minutes open for questions, which generally means we're going to be done in about 30 seconds. But any thoughts, comments, questions? Anybody want to add any insight? Eric, you're crazy. You have no idea what you're talking about? Anything like that?
Eric, there was one question about when you were discussing the budget process, what you meant by lack of raw data.
I have no idea. Was that helpful?
Very helpful, thanks.
I think what I was talking about there was that in order to accumulate the budget, a lot of times what the CFO will do is it will provide kind of the detailed operating stats, then the charges, and help the department managers accumulate the budget, and kind of the staffing, the FTEs, the benefits, those types of things. There's a lot of information that can be provided to the department managers to help them understand how that budget is built up or to help them build up their budgets. I think in the absence of having that detailed information, they just become numbers rather than actual people and patient volume. How's
Eric?
that?
Eric, this is Chris again. You talked about, I think you said maybe the hospital was in Kansas, the CFO had developed, 4 or 5 measures per department. I mean, is there a way to get your hands on stuff like that? I mean, to keep from having to try to create what we think's right. I mean, obviously a lot of these are intuitive, maybe, but what other people are doing is always helpful as well.
I know she moved to a different hospital. Actually, I just had a meeting with her a month ago in Lincoln, Nebraska. Let me shoot a note to her, and I'll ask her that question.
Okay.
See if I can't get that. Any other thoughts or comments?
Yes, Eric, this is Ken Cox.
Hey, Ken.
Maybe you should also bring to their attention that the budgets are not necessarily set in stone, especially for critical access hospitals. After the critical access hospital does an interim cost report, Medicare and Medicaid will adjust their daily rate accordingly.
Mm-hmm.
So make mention that the budgets would have to be adjusted as well according to those rates.
So moved.
For the critical access hospitals, when you do an interim cost report, if depending on the cost to charge ratio, the Medicare and Medicaid will adjust their rates to those hospitals based on the interim cost report. If their daily rates drop, then the budget would have to be adjusted along. Wouldn't you agree?
Right, and but generally that's not as relevant to the department managers that don't have access to that contractual allowance information anyway. That's much more relevant to the CFO and CEO who are dealing with the profit over the overall hospital rather than the quote, well, I don't even want to say quote profit in the department. I want to say rather than the charges and direct expenses of the clinical departments.
Okay.
Okay, Ken?
Okay.